Good morning, everyone, and welcome to our, which one is this, Tyler? Fifth? Sixth. New Hampshire Insurance Department annual hearing on premiums and the insurance market. Welcome. And a special thank you to UNH and UNH Law School for allowing us to use this space. It's perfect for this sort of a hearing. The hearing this morning really is an opportunity to present the findings on the insurance marketplace and create a public forum for related issues. Let me start with the housekeeping, though. Just to make sure as we have in years past, we make sure that no one goes hungry during the hearing and you don't sort of feel weak and that sort of thing. We've provided some food. It's all very low calorie, thanks to Danielle. And coffee as well as juice and those sorts of things out there. We're also going to have a break at 10:20, and during the break there'll be additional refreshments served. If you need more coffee at any time, as always, just feel free to get up and help yourself to more coffee. Logistically, the restrooms are to my left or to your right, just a short ways down the hall. And also you should know that today's event is being recorded. It's not only being recorded, but it's being seen through the internet live stream. So there are folks that are probably watching me, as I speak. I'd like to start by recognizing the following staff that's from the department. Tyler Brannon, Jenny Patterson, David Skye, Michael Wilkie, Maureen Mustard, Al Kuchar, Danielle Barrick, Ariana Spell, and our project manager, Martha McLeod. I saw you somewhere, Martha. There you are. Also with us this morning is our Assistant Commissioner, John Elias. Now I'd like to recognize the staff from Gorman Actuarial, Jenn Smagula, who's going to participate or do the presentation this morning for you. Don Gorman and Linda Keene, who was outside. I don't know if Linda's come in yet, but she was outside just greeting folks as they came in. The department has released a preliminary report that was developed from the data received by the department. A final report's going to be released in early December. The reports can be obtained from our website. This year, it's certainly no secret, has been an exceptionally turbulent one in the health insurance industry. We've seen mixed messages out of Washington, a number of policy-related questions debated at the local level. Meanwhile, increasing healthcare costs continue to be a major concern. And it's open enrollment, so we're starting to hear from consumers about the healthcare costs and the increases that they're going to experience. And in many instances, we find that the renewal notices are what triggers a consumer to call us, and we find that, in fact, it shows the new premium and it shows the old subsidy that they were receiving. So, in fact, they think they're getting an increase that's significantly larger than what they're actually going to get. So we're telling consumers, just go in and take a look. Don't rely strictly on the notice that you've received. The event's going to start with a presentation by Gorman Actuarial on health insurance premiums and our insurance market. The rest of the event's going to be dedicated to hearing directly from our carriers. Our first panel is going to focus on markets, benefit design, and payment reform. The second panel will discuss strategies for managing covered populations and addressing drug costs. A public comment period is going to be permitted at the conclusion of the second panel. After Jenn gets done with her presentation this morning that we're going to start with, if you have a limited question or something of that nature, please feel free to ask her. But I would wait, if it's simply a comment, until after the second panel is finished. We're going to take a 15-minute break, like I said, at 10:20. And with that, let me start by introducing Jenn Smagula from Gorman Actuarial. Jenn?
So I'm Jenn Smagula. I'm a healthcare actuary working with Gorman Actuarial, and I'm joined here today by my colleagues Don Gorman and Linda Keene. And I'm going to take you through this presentation on the key findings from our preliminary report on New Hampshire's 2016 healthcare premium and claim cost drivers. So the goal of the report and the presentation is to examine health insurance premium and claims cost and the factors contributing to changes in those costs. And this year's focus is on 2016. So first we wanted to start with some national comparisons. The uninsured rate in New Hampshire has decreased almost 5 percentage points for residents from a high of 10.7% in 2013 down to 5.9% in 2016. The United States uninsured rate saw a similar decrease, dropping from 15.5% to 8.6%. The New Hampshire uninsured rate remains lower than the national uninsured rate. The significant impacts to the uninsured rate in New Hampshire are the implementation of many of the major provisions of the Affordable Care Act in 2014, along with Medicaid expansion in August of 2014. Another key date that we'll be talking about is when the New Hampshire converted its Medicaid expansion program to a premium assistance program on January 1st, 2016. As of this date, these members are part of the commercial insurance market and will be rated under the single risk pool requirements of the ACA. Individuals eligible for the New Hampshire Premium Assistance Program generally include adults aged 19 to 64 with incomes up to 138% of the federal poverty level, who do not fall into other Medicaid eligibility categories and who do not qualify for Medicare. So while the uninsured rate in New Hampshire continues to decrease, New Hampshire remains as one of the top 10 highest costing states for medical spend through 2014. So this data is from CMS and it represents per capita personal health care expenses by state of residence. Personal health care spending reflects all payers, Medicare, Medicaid, private health insurance, and all other payers and programs. And it includes all the out-of-pocket expenses like co-pays, deductibles, and coinsurance. In 2014, New Hampshire had the 9th highest per capita spend by state at $9,589, which is about 19% higher than the national average. So this chart shows the average annual trend in healthcare spend from 2009 to 2014. The 3.3% trend for New Hampshire is only slightly higher than what was seen on a national basis at 3.1%. In 2009, New Hampshire also had the 9th highest per capita spend by state, so the same rank as 2014. So there hasn't been much change as far as rank from 2009 through 2014. Now, it'll be interesting to continue to analyze this kind of data through 15 and 2016. We know from examining data specific to the individual and small group markets in New Hampshire, which would just be a small subset of this total personal health care expenditure. We know from analyzing those markets that New Hampshire, while they did have some of the highest premiums in 2014 for those market segments, that their rank has come down in 15 and 16. So it'll be interesting to see what happens when you look at total healthcare expenses by state in 15 and 16 once that data is available. So we also know that New Hampshire has one of the highest median household incomes in the nation. In 2014, New Hampshire had the 2nd highest median income compared to any other state. There have been many studies examining the relationship between states' income and healthcare spending, and some have conjectured that the higher the income of the state, the greater the healthcare spend. So the data points in this chart represent each state's median household income versus their healthcare spend in 2014. So New Hampshire's data point, along with the other New England states and the US average, is colored in red. When comparing income and healthcare spend by state, there does appear to be a relationship between income and healthcare spending, where the higher income states generally spend more on healthcare, and that's demonstrated by the black regression line in the chart. So New Hampshire's data point is relatively close to this black line, meaning that their higher income is generally in line with the higher healthcare spending. So this is in contrast to a state like Massachusetts, who also has high income and high healthcare spend, but their healthcare spend is significantly higher than what the relationship between the two might otherwise suggest. And this is demonstrated by the Massachusetts data point being much higher than that black regression line. So next we're going to focus more on New Hampshire and the commercial markets. So by commercial insurance market, we mean those who receive their insurance through their employer or purchase insurance on their own. This slide gives a picture of the membership distribution by insurer for the combined commercial fully insured and self-insured markets in New Hampshire for 2014 and 2016. There are 3 insurers who continue to dominate the commercial markets in New Hampshire: Anthem, which includes Matthew Thornton Health Plan, Harvard Pilgrim, and Cigna. Now, there were 2 new entrants in 2015, Minuteman Health and Community Health Options, each who had members primarily in the individual market, but also some small membership in the small group market. In 2016, Ambetter started offering their individual market product primarily to New Hampshire Premium Assistance Program members, or PAP members. Tufts was also a new market entrant to the small group and large group market in 2016. So while the large group, fully insured, and self-insured markets have seen minimal shifts in membership by insured, the individual and small group markets have experienced large shifts. So this slide presents the membership distribution for the small group market for 2014 and 2016. So Anthem, Matthew Thornton, and Harvard Pilgrim continue to be the dominant insurers during this time period. But as you can see, Harvard Pilgrim has gained market share from Anthem, increasing from 34% to 45%, and that's shown in red. In addition, Community Health Options, who again entered the market in 2015, represented 8% of the small group market in 2016. Community Health Options has exited the market in 2017, so we'll see their membership shift back to other insurers in future years. The individual market has experienced the most significant shifts from 2014 to 2016. In 2014, virtually all of the individual market members were enrolled with Anthem Matthew Thornton. In 2016, there are 5 insurers, each with market share of 5% or greater. Ambetter represents 18% of the individual market, as shown in green, and virtually all of their membership is from the New Hampshire PAP program. Community Health Options had the smallest market share in 2016 at 5%, and again, they've exited come 2017. Minuteman had 17% market share in 2016, and they will be exiting in 2018. So we'll continue to see shifts in this market segment in 2017 and beyond, given the exiting of some of these insurers. So this slide summarizes the large amount of fluctuation in the individual market and the individual health insurance marketplace exchange. It gives a picture of the entering and exiting of insurers from 2014 to 2018. In 2014, Matthew Thornton Health Plan was the only insurer on the exchange in New Hampshire, represented by that dark blue box in 2014. This compares to 2015 and 2016, where there were 5 insurers on the exchange. Now, in 2017 and 2018, the number of insurers participating will decrease again with the exiting of Minuteman and Community Health. So all of these insurers are for different products with different provider networks. In addition, with the introduction of the New Hampshire PAP population in 2016, all these changes have contributed an additional level of complexity to the individual market. And all of these changes combined result in fluctuations when examining premiums and claims over time. So this slide presents an overview of the key components of premium for each market segment within the commercial fully insured markets. So there's a couple notes related to these slides before we look at the data. So this information is based on each insurer's federal MLR rebate form, but note that these loss ratios are not the same as the MLRs that are used in the rebate calculation, as there are several additional adjustments made in that calculation. And this information is shown prior to any federal MLR rebate payments that have happened in 2016. Once that information is made public, we'll reflect that in the final report. And the total premium used in these loss ratios are reflective of any federal reinsurance and risk adjustment payment and receivables in calendar year 16. And in addition, the medical costs are reflective of the cost sharing reduction subsidy payments from the federal government in 2016. So the percentage of premium from medical and pharmacy claims is 83% in the individual market, 82% in the small group market, and 81% in the large group market. In the small group market, the percentage of claims from medical and pharmacy services has increased 5 percentage points. It was 77% last year in 2015, and now again it's 82% in 2016. So in conjunction with that increase in the percent spent on medical and pharmacy, the profit margin in this segment has decreased from 8% in 2015 to what's being shown here, 3% in 2016. The large group market also saw a decrease in their profit margin, but to a smaller extent. In the large group market, the profit margin went from 7% in 2015 to 6% being shown here in 2016. In the individual market, the profit margin in 2016 continues to be negative, and it's currently at a negative 3% in 2016. So similar to last year, the negative profit margin is driven in part by the new market entrants, Minuteman and Community Health Options, who generally experience higher administrative per member per month costs and much higher claims to premium ratios compared to their competitors. Now, in each market segment, about 1 to 2% of premiums are used for ACA-related fees, which is shown in maroon in these pie charts. And this includes the ACA health insurance tax, the PCORI fee, and the transitional reinsurance fees. The federal transitional reinsurance program ends in 2016, so we'll see those fees eliminated in future years, but offsetting that, the premiums for the individual market will be higher in 2017 as a result of the elimination of that program. So we know in 2016 that $19 million in federal reinsurance payments were made to New Hampshire individual market insurers. So that reduced premiums in 2016 about 4%. So we're now going to drill further into the individual market. This slide focuses on the fully insured membership within the commercial market and how that membership has changed over time. The overall fully insured market in New Hampshire grew from approximately 231,000 members in 2015 to 279,000 members in 2017. A large portion of this growth is due to the introduction of the New Hampshire PAP program. In 2017, there were 43,000 members in the New Hampshire PAP, or Premium Assistance Program, and that represents 15% of the fully insured market. Now, the individual market exchange membership also grew during this time frame, picking up approximately 4,000 members from 2015 to 2016. 17. So this slide demonstrates the diversity within the individual market and further shows the breakdown of the individual market beyond the exchange and non-exchange populations. In addition to the impact of different insurers moving in and out of the individual market, which we just talked about, there are also several subpopulations within this segment with different distribution channels, different risk characteristics, and different product choices, which further makes the individual market a diverse and complex market to analyze. For example, on the left side of this slide, we show the 16,000 members, or 15% of the market, who do not purchase insurance through the exchange. Within the non-exchange population, about 7,000 members are grandfathered or transitional, while the other 9,000 are not. The grandfathered transitional populations are not subject to the single risk pool rating requirements of the ACA. On the right side, we have the 88,000 exchange members, and again, 43,000 of these members are part of the New Hampshire PAP program, which again is the Medicaid expansion population. The remaining 45,000 members are on the exchange, but just outside of the Medicaid Premium Assistance Program, but many of these members are still getting assistance in the form of cost-sharing reduction subsidies and federal premium subsidies. So 16,000 of those members on the exchange are getting both cost-sharing reduction subsidies and federal premium subsidies. 13,000 are just getting the federal premium subsidies, and the remaining 16,000 in that blue box are not receiving any type of financial premium assistance. So the membership segments in this chart outlined in blue represent populations that are not getting any type of federal funding assistance, and the populations outlined in green are getting some type of financial assistance. So I just wanted to pause here to focus on this single risk pool concept that I've mentioned a couple times now. The single risk pool is a concept under the ACA where the claims experience from all the enrollees have to be considered when an insurer calculates premiums for that market segment. So in New Hampshire, all of the segments shown in this slide are included as part of that single risk pool, except for those grandfathered transitional members that are outlined in red. The grandfathered transitional members are exempt from this single risk pool provision per the ACA, and therefore they continue to be rated separately from the rest of the individual market. So when focusing on this individual single risk pool market, which again was all those segments except for the grandfathered transitional population, we see that 74% of members received some type of subsidy towards their health insurance premiums in 2017. A large portion of this subsidized population is the New Hampshire PAP program, and that represents 44% of the single market risk pool. New Hampshire PAP members do not pay any premium. Their premium is fully subsidized. The remaining subsidized populations receive federal premium subsidies, or also referred to as advanced premium tax credits. This means that at least some portion of their premium will be subsidized based on their income level. Now, the 25,000 members shown in blue, or 26% of this single risk pool, receive no subsidy. So therefore, they'll feel the future impact of any future rate increases. This slide shows an illustrative example of what a 50-year-old single policy holder in New Hampshire would pay in 2018 at various income levels. On the far left, we have the New Hampshire PAP members. These members are in platinum equivalent plans, meaning they pay very little or no cost sharing. And the premiums, again, are fully subsidized, primarily through federal subsidies, so they pay no premiums. So they're shown in zero way on the left. Now, federal premium subsidies are those APTCs. They're available to folks on a sliding scale to individuals qualifying with incomes less than 400% of the federal poverty level. So in this example, APTC members, the ones shown in green, will pay between $729 a year up to $4,612 a year, depending on their income level. Now, at the far right in blue, we have what a non-subsidized individual will pay in this example, and that's $8,527. So this is almost double what an individual earning up to earning 400% of the federal poverty level will pay, and almost 12 times what an individual earning 150% of the federal poverty level will pay. So while the overall average premium increases were fairly flat in 2014 to 2015 in the individual market, so the 366 average to the 368, there was an increase of 6.2% in overall average individual market premiums. This increase is driven in part by the introduction of the New Hampshire PAP program, along with increases that were seen in the grandfathered and transitional populations and the non-exchange populations. So offsetting these increases, we also saw a shift within the exchange population to more limited network products, and there was also a shift to more higher cost sharing products, which helped mitigate these premium increases. So note that these average premiums shown here are shown prior to any federal premium subsidies. And the premiums shown here reflect the actual mix of demographics and plan designs purchased during this time period. So the average premium levels and premium trends presented here are different than the rates and the rate increases published by CMS and other news sources, because those rates and rate increases typically reflect a static population and a static plan design. This slide shows average deductibles for several segments within the individual market for both 2014, which is shown in blue, and 2016, which is shown in red. Across the whole individual market, average deductible levels increased 11% in 2016 compared to 2014, but as you can see, the changes vary by segment. The first three sets of bars reflect average deductibles for members with cost-sharing reduction subsidies. There are three kinds of CSR subsidies which vary by income level. So the 94% CSR, which is shown on the far left, those are the richest plan designs, and they have the lowest cost sharing, and those are what's offered to folks at the lowest income levels. This is followed by the 87% plan designs and the 73% CSR. These segments, as you can see, saw a very modest average dollar increase in their average deductible from 2014 to 2016. Now, the exchange population, the non-CSR, which is labeled as D in the middle of this slide, they saw the largest increase, both in terms of dollar and percentages, increasing 18.6% from that $3,279 to the $3,887. The non-exchange population, which is labeled as E, and the grandfathered and transitional population way on the right, which is labeled as F, they actually saw slight decreases in their average deductible. And note, in this chart and some of our subsequent slides, the grandfathered and transitional population is shaded differently to highlight that it's not a part of the single risk pool, which again means that they're rated separately from other segments within the individual market. This chart also shows the differences in the average deductibles by segment. So the populations with those CSR subsidies, which are all on the left, A, B, and C, Their overall average deductible in 2016 was $1,043, while the non-subsidized populations within the single risk pool, so the D and E, they had average deductibles of around $3,800, so almost 3 times what the folks in the CSR subsidy buckets are paying. And note the New Hampshire Premium Assistance members are not included in this slide since they have very little cost sharing. So risk adjustment is one of the risk mitigation programs that was implemented under the ACA. The risk adjustment program generally redistributes funds from insurers with lower risk or healthier enrollees to insurers with higher risk or sicker employees. So health plans that have healthier members will end up paying, and that's shown in red, and health plans who have sicker members will end up receiving money, and that's shown in black. This program is a permanent program that started in 2014, and it is revenue neutral within the New Hampshire individual market and separately within the New Hampshire small group market. So this slide shows the results in the individual market in New Hampshire from 2014 through 2016. So focusing on 2016, you can see Minuteman was the largest payer in the individual market in calendar year 16, and they paid $25.4 million, which means they enrolled on average healthier people. Alternatively, Ambetter was the largest receiver in 2016, receiving $17.3 million, which means they enrolled on average sicker people. And again, Ambetter's population is primarily all New Hampshire Premium Assistance Program members. Now, when comparing the results from 2014 through 2016, the impact of the new market participants and the introduction of the New Hampshire PAC program is evident. In 2014, approximately $5 million was redistributed among insurers, versus when we get to 2016, almost 5 times that amount is redistributed, or that $25.9 million. And when comparing risk adjustment payments per member by state, New Hampshire is in the top third across the country in 2016 as far as the amount that's redistributed across insurers. So now these next couple slides focus on the average allowed claims per member per month for different segments within the individual market. The total 2016 individual market trend is 23.2%, and this includes the New Hampshire PAP population. The individual market trend, excluding the New Hampshire PAP population, is 10.6, or 12.6 percentage points less than the trend, including the New Hampshire PAP enrollees. The grandfathered and transitional population had the lowest trend at 6.9%. Now, within each of these populations, we saw that inpatient and pharmacy services were some of the key drivers of the increasing costs. So the last slide focused on the allowed claim trends from 15 to 16, and this slide focuses on the allowed claim levels in 2016. When comparing allowed claims PMPM for the different segments, a similar pattern is seen where the PAP population claims PMPM levels are significantly higher than other segments. In 2016, the PAP population average allowed claims cost was $539, shown right in the middle, which is 24% higher than the combined exchange and non-exchange population PMPMs, which is at the $433. So when examining allowed claims PMPM by service category, inpatient PMPMs are a significant driver of the differences between the PAP population and the non-PAP population. So inpatient allowed PMPM costs for the PAP population is at $122. And for the non-PAP population, it averaged to $80 across the exchange and non-exchange. So this is a difference of about $42 PMPM, or 53%. So we drilled further into the differences between the PAP and the non-PAP populations, and we saw significant differences in utilization for certain service categories. So two examples of this are inpatient admits per thousand and emergency department visits per thousand. So in 2016, the PAP population had inpatient admits that were 72% higher than the non-PAP population. So this is shown on the chart on the left. And then when you look at emergency department visits on the right, they had ED visits that were 300% higher, or almost 300% higher than the non-PAP population. So lastly, we compared utilization levels in the individual market with the small group and large group markets. So the individual market, including New Hampshire PAP, has higher utilization than the group markets for both inpatient admits and emergency department visits in 2016. So the inpatient admits and the emergency department visits and the group markets, they're in line with what we saw from benchmark data from the Healthcare Cost Institute 2015 reports, and that's represented by that black line. So for instance, on the inpatient side, the Healthcare Cost Institute had admits at 51 admits per thousand. The small group utilization came in slightly lower than that. The large group came in slightly higher. Now note that as we saw on the previous slide, the inpatient and emergency department utilization in the individual market, excluding PAP, is actually more in line with the levels we see in the group markets. So for example, the inpatient admits for the individual market, excluding PAP, is at 53.6%, which is right in between where the small group and large group inpatient admits come in, the 45 and the 55. And again, it's pretty close to that Healthcare Cost Institute benchmark of 51. And similarly, you can see the same results when you look at emergency department. So when you look at the individual market, excluding PAP, their ED visits per thousand came in at 181, which is right around where it's right in between the small group and large group metric. So we focused on the premiums, allowed claims trends for the individual market, and now we're going to turn our attention to what's going on in the small group and large group, fully insured markets. Overall premium increases across all market segments was fairly minimal at 0.6%, but as you can see, there are differences by market segment. In the small group market, average premiums actually decreased 1% in 2016, while average premiums in the large group markets increased 4.4%. So this combined group market premium trend comes in at 2.2%. Now the premiums shown here include both the employer and employee portion of the costs that is paid in the group markets. National data show that 2016 premium trends in the group market for this same time period was between 3 and 4%. So the trends we're seeing here in the New Hampshire group market is actually very much in line with that and even slightly lower. So we know from the 2016 small group rate filings that there were low and even negative rate changes filed during this time period. So this would lead to minimal need for benefit buy down for groups to move to higher cost sharing plans with things like higher deductibles. And this is seen when we look at the deductible distribution changes from 2014 to 2016. So while the percentage of members with a deductible less than 1,000 shown on the left increased, at the same time we also saw an increase on the far right where deductibles greater than or equal to 5,000. So on the left we see it went from 0 to 5%, and that's the lowest deductible level. And on the right we see where the highest deductibles are. That also went up roughly 6 to 7%. So this resulted in an overall minimal increase in the average deductible from 2014 to 2016. We saw just a $31 increase in that deductible. This slide shows the results of the risk adjustment program in the small group market. So compared to the individual market, a smaller total amount is redistributed among insurers. So here we're showing in 2016 approximately $6.2 million in the small group market versus the $25.9 million we saw a couple slides back in the individual market. Community Health Options and Harvard Pilgrim Healthcare of New England were the largest payers, shown in red in the small group market, which means they, on average, enrolled healthier people in their plans. Alternatively, Harvard Pilgrim Insurance Company and Anthem Matthew Thornton enrolled sicker people on average, and they received money through this program, which is shown in black. And when comparing, similar to what we did on the individual side, when comparing the amount of risk adjustment money that's redistributed among insurers by state, New Hampshire was also in the top third across the country as far as the amount that's redistributed among insurers. This slide shows the overall average allowed per member per month annual trends by market segment for the past 3 years. Observed allowed claims per member per month in the overall fully insured market came in at 8.6%, which is shown on the right in that red bar. So this represents an average increase over what we saw the prior year at 3.7%, and then at 2.5% in 2014. So we've already discussed the increase in the individual market, which is shown in the bars on the left, at 23.2%, and some of the drivers being the inclusion of the New Hampshire PAP population. But we also can see in the small group and large group market, they have experienced an uptick in their trend in 2016 compared to the prior year. So in the small group market, we see the 4.7% in 2016 compared to the 3.4% from last year. And in the large group, we see the 4.4% in 2016 compared to the 1.9% from the prior year. When we look at the overall combined trend for the group markets in 2016, that number came in at 4.6%. So this chart takes that combined group market trend, the 4.6%, and it breaks it into two components, utilization and unit cost and mix. Now, utilization reflects the number of services provided, and unit cost and mix represent a combination of a couple things. It can represent increases in the actual underlying cost or prices of specific services, and it also reflects any change in the mix of services or the mix of providers experienced that year. So in 2016, roughly half of that 4.6% came from utilization increases, and the other half came from the cost and mix bucket. So as you can see, this is a significant difference in what was happening and what we've seen in the prior years, where in 2014 and 2015, you can see the utilization trends were actually negative. So they were helping keeping overall costs down, this decreasing utilization, where the cost and mix trends were positive. So the overall impact of this is driving up trends when you look at 15 to 16. The other interesting thing is when we look at the information by service category in 2014 and 2015, in each service category, so inpatient, outpatient, pharmacy, etc., we saw flat or negative utilization. Now that we're in 16, in each of those service categories, we're seeing the opposite. So some are still flat, but a lot of them are all increasing on the utilization side. So this slide examines the allowed claim trends by service category for the combined small group and large group market. So starting on the left with the inpatient facility trends, you can see we've seen some fairly large swings in trends when we look at 14, 15, and 16. The increase in trends in 2016 on the inpatient side was driven by both increases in cost and utilization. Insurers pointed to admissions related to musculoskeletal, neoplasm, and other high-cost cases as the drivers of some of these increases in those inpatient trends. Given the fluctuation that we've seen in trends for some of these service categories, like inpatient, it can be useful to examine trends over a multiple year period. So over the 2014 to 2016 time period, the inpatient trend is 5%. When we move over to the outpatient and professional category, we've also seen an increase in trend in those categories, and those categories is primarily driven by utilization increases. Now the other category, which is way on the right, it's a fairly small category that's made up of several different components, and it only represents about 6% of total spend. But as you can see, there's been some very large trends in the past couple years in this category. And one of the drivers that insurers point to in this category are drugs. So drugs that are under the medical benefit, they're typically administered in a physician office, so they're high costing injectables. Now the middle bucket, pharmacy, we can see that pharmacy trends have decreased from 2015 to 2016. They were at 6.1% last year, and now they're at 3.3%. So this appears to be consistent with what is happening nationally. Pharmacy trends have come down in 16. And some of the insurers pointed to some of the drivers, or one of the drivers, as hepatitis C drugs. So the hepatitis C drugs was one of the key reasons why why the trends went up so much in 15 and 16. And now that utilization and cost has leveled off, it's helping bring down the trends in 2016. In addition, other insurers pointed to the increased use of generics in 2016 that helped keep the pharmacy trends lower than what we saw in the prior year. So over this time period, 14 to 16, the pharmacy trend is at 15%. And pharmacy represents, in 2016, about 19% of the total medical spend.
Where in there is ED utilization? Is it in the inpatient?
It's an outpatient.
It's an outpatient. Thank you.
So now we're going to drill a little bit more into pharmacy. So this slide combines the trend information that we were just looking at, 14 to 16, with the size of each of the service categories to understand the overall impact of each service category to trend over the past couple years. So pharmacy has had the largest overall impact to trend for the past couple years at 37%, followed by professional services, and then that other category. So within pharmacy, specialty drugs is a main driver of increasing costs. As shown in the chart above, specialty pharmacy trends increased 18% in 2015 and 14% in 2016. So that results in a 35% trend increase over these 2 years. So during the same time, generic and brand non-specialty drugs, which is shown on the left, they've actually stayed overall fairly flat or have even decreased slightly. Now, when we look at the changes by utilization and cost, the change in generic drugs is driven by decreasing costs, and offset partially by increasing utilization. Now, that's the opposite is happening when you look at the brand drugs, where the brand's utilization is decreasing, but their costs are going up, but they generally offset each other to overall stay fairly flat. Now, when you look in the specialty bucket, both the utilization and the costs are increasing, which is driving up this overall trend. The right side of this chart shows pharmacy drug costs covered under the medical benefit, which we were just talking about earlier. It includes prescription drugs that are administered at a physician's office or in a hospital setting. And in many cases, these are high-costing injectables. So pharmacy costs paid or covered under the medical benefit represents on average an additional $30 PMPM in 2016, and this category trended at 20% from 14 to 15 and another 10% from 15 to 16. So the costs and the levels and the trends for this category, this pharmacy under the medical benefit, is actually fairly similar to what we see on the specialty drug side. Now, if we were to combine the costs on the right, so all the drugs that are paid on the medical benefit, if we were to include that in the overall pharmacy trends, we would see that 3.3% pharmacy trend go up to 5% in 2016. So as specialty drug spending increases at a much higher rate than non-specialty drug spending, specialty drugs have become a larger and larger portion of overall pharmacy spending. In 2014, we saw about 30% of the pharmacy spend go towards specialty drugs, and that's climbed to 37% in 2016. And that 37% level and the increase over time, this is also consistent when you look at national data, what's happening. So the last couple slides focused on the pharmacy trends within the group market, and this slide focused on the pharmacy trend within the individual market. So similar to the group markets, pharmacy costs are one of the significant drivers of overall trend, and in fact the trends are on the pharmacy side are even higher in the individual market than what we saw on the group side. So this chart shows the overall pharmacy trend for the individual non-PAP population, so excluding the PAP members. It came in at 23.6% at 2016. And this is driven by a specialty drug trend of 37%. So again, the specialty drugs are driving the overall pharmacy costs in the individual market and to an even higher extent in the individual market. Now, in the individual non-PAP market that we're looking at here, specialty drugs costs represent 44% of total pharmacy. So that compares back to the 37% we saw in the group market. So again, much higher. So these last set of slides that we're going to talk about focuses on the self-insured market. And it compares them to the large group fully insured market in New Hampshire. So by fully insured, we mean that an employer group pays a premium to a health insurer, and that insurer takes on all the risk and pays for the claims for the members in that large group. This is in contrast to a self-insured arrangement where the insurer still administers the benefit, but it is the employer who is ultimately responsible for paying the claims for their employees and members. So in New Hampshire, the self-insured market is much larger than the fully insured large group market. There's about 262,000 members in the self-insured market in 2016 versus 101,000 in the large group fully insured market. Now, this mix of fully insured, self-insured within the large group population has been fairly consistent over time. So back in 2010, about 70% of the large group market was self-insured, and that same metric is 72% in 2016. So that mix has stayed fairly constant. Now, in the fully insured market, which we're showing on the left, Harvard Pilgrim is the market leader with 40% of the market shown in red, followed by Anthem at 43%. Now, this contrasts with the self-insured market shown on the right, where Anthem is the market leader at 41%, followed by Cigna in green at 33%. So Cigna has a much larger presence in the self-insured market compared to the fully insured market. This chart compares the allowed claims PMPM for the large group fully insured market with the self-insured market. In 2016, total allowed claims PMPM for this fully insured market came in at $492, and that compares to $502 on the self-insured side. So they're very similar. The age demographics are also very similar for these two populations when we looked at that. But we know that the plan designs and the cost sharing for these two populations are not similar. So in 2016, the large group market members paid on average $84 in member cost sharing. So that's shown in orange. So this translates to about 17% of their total allowed spend. Now this compares to the self-insured side, where those members paid $47 on average in the large group market, or that's approximately 9% of total cost. So this shows that members on the self-insured side, generally they have lower copays, lower deductibles, and coinsurance as compared to their counterparts on the fully insured side. And we know from examining other data, about 40% of the self-insured market are state and municipal employees, and their plan designs are richer and have lower cost sharing. This slide compares the percentage of premiums spent on medical and pharmacy claims for both the fully insured and self-insured large group segments. In the fully insured market, 81% is spent on medical and pharmacy claims, and the remainder goes towards admin costs, taxes and fees, and any profit or risk margin. So we saw that 81% several slides back. Now in the self-insured market, 93% of the total amount paid out or collected goes towards medical and pharmacy claims, and the remainder goes towards admin, taxes and fees, and any profit. So generally, insurers need to retain more of the health insurance premium in the fully insured market, because in addition to administrating the benefit, they also are taking on all the risk by paying the claims for those folks. In addition, self-insured counts are generally much larger than fully insured counts, so there's an economy of scale recognized, which allows insurers to have lower admin fees on the self-insured side versus the fully insured side. So this last slide summarizes our key findings from this year's report and presentation. So New Hampshire, again, is one of the top 10 states by medical expenditures from 2009 through 2014, and it's currently about 19% higher than the national average. The uninsured rate in New Hampshire has decreased over the past several years due to the implementation of the ACA and Medicaid expansion, and the decrease that we saw in New Hampshire is consistent with the decrease seen on the national level. Through 2016, the uninsured rate continues to be lower than the national rate. The inclusion of the New Hampshire PAP population in the individual market was a key driver of increases in claims, as seen in their overall higher claims PMPM, including higher inpatient spend and higher emergency department visits. So while individual and large group premiums have increased 4 to 6% in 2016 over 2015, small group average premiums actually decreased during this time period, and we also saw minimal benefit buy down. Increasing utilization trends across nearly all market segments and all service categories have contributed to the increase in medical claims costs, which is a big change compared to what we saw in the prior years, where unit cost and mix were some of the key drivers. Pharmacy trends have declined in 2016 compared to 2015, but they still continue to be the largest contributor of overall costs over the whole medical spend, and this is due in large part to specialty drug costs and utilization increases. And lastly, when we focus on the self-insured markets, it's considerably larger than the large group fully insured market, and their overall claim costs and demographics are similar, but they generally have richer benefits with lower cost sharing. So the full preliminary annual hearing report is available on the NHID website, and this provides even more context and additional information beyond all the information talked about in this presentation. So before we take questions, I just want to thank everyone on the NHID staff for all of your help and support, to all the New Hampshire insurers who contributed all the data and information that went into this presentation, and all the other stakeholders in New Hampshire who helped us with this. And now we're going to open up for questions. Yep.
When you say we're in the top 1/3 in the amount of premium redistributed, is that by dollar amount, or if you adjust that for the numbers of population, where does that put you?
So that's what I'm just going to go back to that slide so we can all. Yeah, so this was by, I made that comment, we looked at it was by member by state. So we accounted for, obviously, yeah, certain states have more people than others. So it was on a total dollars redistributed per member by state. Yep. Yeah.
So a question about the pharmacy portion of the presentation. First of all, this gets better every year. It's not a reflection of last year's presentation, but so thank you for your work, particularly on the pharmacy side, really interesting. This year you added some focused comments around the drugs under the pharmacy benefit as opposed to under the medical benefit. And that's helpful. I wonder if we can get to a point, or if you've considered getting to a point where we remove that black line and we just look at pharmacy in total, particularly when you consider that carriers have different ways of moving drugs from the medical benefit to the pharmacy benefit. It's not such a hard and fast line that divides them. And I always feel like when we're looking at drugs only on the pharmacy benefit, we're understating the impact globally on pharmacy.
I mean, I would say we agree with your point, and I think some of the discussion that occurred last year really drove us to start looking at this a little differently, and working with the insurers. We collected this information differently, really focusing on all those drug costs under the medical benefit, because I think exactly to your point and what we're showing here, they're a large growing part of overall spend that I think definitely gets overlooked sometimes. So I think, we feel like we're moving in that direction, and your point, perhaps we even let's just throw it all together and look at it all together is a good comment.
You can certainly see the numbers if you're just looking at the pharmacy benefit side, because there's migration across that black line, you could actually be drawing the wrong conclusions.
Mm-hmm.
Thank you.
I was looking at the PAP population, and I'm thinking that they both mainly come from the ranks of the uninsured, who are more accustomed to getting whatever medical care they get from the emergency room. Do you think it's reasonable to expect that the PAP population will not have the same decrease as they learn how to work with medical insurance?
They will or they won't? They will?
It will decrease because they learn how to work with regular healthcare providers.
I think that is very likely. I'm sure the insurers in this room that are managing this population, I'm sure they have all this data that we have, and I'm sure that's high on their list to help better educate and offer different solutions to these folks beyond the emergency department. So I'm sure maybe even that will come up in some of the panelists' discussion later today. So I'm just going to look to see who I saw first.
The same type of question, which is, did you compare the 16,000 who are getting cost-sharing reductions and subsidies in the individual market with the PAP population around utilization and cost?
I'm not specifically showing it here, but our team has done a lot of other work with the insurance department over the summer, specifically focusing even more on the PAP population. And that was one of the things we looked at. So those CSR folks who are on the low income scale, and they're not, in some cases, they're not that much higher income than the PAP population. And yes, their utilization and overall claims cost, and mostly their claim cost is what we examined, are not significantly higher than the PAP population. Or we can see by income, the higher when you line up the PAP and then the CSR populations and then all the non-CSR, the claim relativity steadily increases. And there's actually several reports on the New Hampshire Department's website that you can get all that information on.
Is it possible to include that in this, or is that?
Yeah, we can talk. I mean, it's all. Yeah, we can talk about that. It would be easy to include that as well. Yeah, in the final report. I think I saw someone over here first.
Well, this gentleman's question, or point about as people learn to use the system appropriately. I mean, didn't they find that out in Oregon, which, you know, had an insured, like a Medicaid expansion years before even the ACA was in place, that initially they were sicker, they were unaccustomed to, you know, suddenly they had access to at least go to the emergency room and so on, but that as that population first of all, became healthier, and secondly, learned how to use the medical system appropriately, didn't those costs come down?
I'm not familiar with that particular study, but I mean, it seems to make sense. And I mean, yeah, that's something that would be interesting probably to look at. Or again, I'm sure the insurers in this room are looking at that to try to understand how to manage that population.
And I actually had a question on your first point on, you know, the key takeaways for the report. Were that medical costs in New Hampshire were higher than average than nationally. Is in the top 10 states by medical expenditures. Has that got anything to do with the age of the state?
I would most definitely. I would think. I mean, we didn't. You know, we looked at the income because we thought that's probably one of the top reasons when people start to think about why is certain states higher than another. Income's got to do with it. I would think the next on the list is age. So yeah, and I think there's definitely some stats. I think New Hampshire has one of the highest overall ages of the whole, maybe not the highest, but
second or third
right.
Oldest state in the country.
Yeah.
I think. Thanks.
Yeah.
I'm referring to slide 43. Is there a reason why you chose to look at this on a PM basis, comparing these two populations, the self-funded versus fully insured, where you can have all kinds of hidden variables affecting those, like where they happen to go geographically or plan design benefits that might hide differences in negotiated reimbursement rates?
Well, I guess I would say, I think throughout this report, as you can see, we really do focus on this total allowed PMPM because we feel like that's the best way. It includes all the differences, whether it's utilization, where they're going to different hospitals. It's a kind of an all-in total medical expense number. So we weren't using this slide there's probably other differences between fully insured and self-insured, but we use this because we just wanted to start with, when you look at the all-in number, how do they compare, and then we did drill into the benefit design. We do know from the information that we asked of the insurers, as far as reimbursement rates, typically there's not any major differences in reimbursement between a fully insured and self-insured member when you look at provider contracts.
Did you look at those contracts? In the report, your bullet just says that insurers responded that provider reimbursement is the same between the two markets. Did you actually look at that?
We do not. We don't collect provider contracts. We relied on the insurers to give us that information.
But in the APCD limited use data set that you have access to do this, you do have access to see certain like CPT codes and the allowed
I don't know.
amounts. for them,
Tyler's
right?
actually done a lot of work, I think, with that. So
Yeah, so Gorman wasn't working directly with the CHIS.
Oh, okay.
But
So they
yeah.
didn't have access to look at that specifically.
Right,
for
right.
this.
I mean-
I gotcha. Okay, thank you.
yeah.
It's been suggested previously that some of the higher inpatient utilization in the PAP group is because individuals are determined to be eligible during an event, during a sickness, whereas the other people in the individual market may have enrolled during the open enrollment period. Are you able to tease that out?
I have heard that as well. I think we've heard both sides. I'm not entirely sure what's happening. Like, is eligibility determined when they come into the inpatient room? I think it's a really interesting question that would be interesting to explore. We don't have the data to necessarily look at that, but I mean, I think that would be maybe another topic for the insurers on the panels later, if that's something that, how does that actually work, and is that something they've looked at?
On figure 10, the non-exchange through the non-grandfathered, in terms of the issue that we see in the state with the exchange population seeing, certain segments seeing that 50% or more increase, what's happening in that, the non-grandfathered group under the non-exchange?
So what's happening to them in 2018?
In other words, if I'm an individual and buying on the exchange and I'm not receiving a subsidy, I'm seeing 50% increase, but if I was in the on the left-hand side, non-grandfathered, what type of increase would I be seeing?
Oh, okay. Yeah, so those people are in the same bucket as the folks on the exchange who are not getting subsidies. So I would say when that roughly average 50% that's quoted now, and that's the average rate increase in 2018, those are impacting both those people on outside of the exchange and inside exchange. So both of those two blue buckets in the solid blue.
How about the red?
The red is, I don't think I brought that with me. I mean, they're rated separately, so they're not part of that 50%. I don't know offhand what the average rate increase
That's
for.
what your question was.
Yes.
Oh, sorry, the red you were talking about.
Both
Okay.
angles, yes, thank you.
I don't know that number offhand, but they're rated separately, so they're not. They're outside of that 50%, and I don't know the number offhand. I guess I would also add, so that's a closed block, that's a shrinking block. People can't come into that red box, the grandfathered transitional. It's shrinking over time. Yep.
When you're considering total allowed claims, are you considering things like risk-sharing arrangements with providers, or are you just looking at the claims cost?
When we collect data from the insurers, we are instructing them to include all payments that they make, so all those what we call non-fee-for-service payments. So yeah.
And payments that come back in, like risk-sharing payments that come back from providers or rebates from pharmaceutical companies?
Yeah, we specifically have accounted for rebates, and again, yeah, any type of outside of the claim payments, we've asked for the insurers to include all that when they report it to us. Sorry.
Did you learn anything about the high cost sharing plans or the impact of cost sharing with employees, so the employee burden on utilization or trend from your analysis?
We did not specifically look at that. I mean, I think there's a lot of other studies out there that have the data and looked at how cost sharing may impact utilization over time. So yeah, I mean, I think that's definitely a contributor. I mean, there's a general consensus that or data that shows increasing cost sharing is going to increasing utilization to a point. I mean, I think at some point it's not going to impact it, this kind of diminishing returns, but that's not something we specifically looked at here.
The premium dollars that you talk about in all of these slides, are those billed premium dollars or are they collected premium dollars? And you know the percentage difference average across the state?
I do not. I would say these are all, this is all, I think of it as earned premium. This is all the premium that was accounted for the members in this year. Whether or not it was billed or collected, we haven't studied that or don't have that data. Yeah.
Just a quick question. When the insurance companies report information to you about their claims and everything, do they have to adhere to the opt-in from like GoBay, or is that something, like, are you getting all the self-funded data that is out there, or is it limited because of the lack of opt-in? I don't know.
Just for clarification on Gorman's role, their primary emphasis is on the fully insured market, where the risk determination is irrelevant.
Sure.
They included in the presentation, included as a part of
what the department collects in aggregate are high-level numbers on the self-funded market, which should include all of those accounts. But you're talking more specifically about the CHIZ and the impact on CHIZ.
Yeah, I wasn't
and there is an
really,
impact
I was
there.
kind of more of a general question
Yeah.
about everything when you're comparing, you know, all the even high-level stuff. So you do have high-level information about all the self-funded groups, but not necessarily
Yeah, that's
detailed
what I'm saying,
claims.
sure. I mean,
Okay.
there are always certain questions that could come up. I mean, whether or not the federal employee program is correctly accounted for, whether or not there are certain accounts that may be in or out.
Yeah.
But in general, yeah, it's one way of looking at sort of the characteristics of our market. Sure, half the people are under self-funded policies. It's good to have some sense of what's going on.
Yeah. Okay.
All right, thank you, everyone.
Jen, thank you so much. That was a really good presentation. And as, I'm not sure who said, was it Matt? Matt said that it continues to get better and better each year. So keep practicing. We look forward to upcoming years. But again, thank you so much. Great questions from everyone. We're ending a little bit early, so why don't we go on a 15-minute break and be back in here by 10:30 to start the first panel. Okay. First, let me introduce DJ Betancourt from the Governor's Office. He's the Chief Policy Advisor, and he works very closely with the Insurance Department on policy matters.